it's not the most sophisticated. But all right, so I think is that going to be start? Yeah. And so I have a set of questions for David, and also, of course, I have a set of questions for you as well. And if I may ask, what capacity are you here?
Oh, I'm Jonathan Briggs. I'm with PCI.
Okay.
Public relations.
Okay. So I just
sitting.
Just wanted to be. Okay.
Oh,
thank you.
Fine.
And of course, Tracy's here. And so, as I said, yes. So I have a set of questions for David, and there's a set of questions for you, and then some will obviously be shared, of course. And essentially, as with all interviews, the questions may not come in the exact order that they've been asked. We'll do some editing and so on. I just wanted to have that on tape out there. So, congratulations!
Thank you
on the new position. So the first question is, what you've been with FC since 1991. And you've been working a lot, of course. You're one of the best-known people working on AIDS.
Oh, thank
you. What made you? And you're a figure in the city with a long history on AIDS activism nationally as well. And Howard Brown, of course, has had a somewhat troubled history in the last few years. What made you decide to move?
Well, thank you for coming. I'm excited about this opportunity. My work most recently, but really in HIV since I joined, has been around addressing health inequality. And right now, there is such a huge opportunity with the Affordable Care Act for us to expand and improve health. By expanding access to health insurance, and that work. It's exciting. It will require us to be deliberate in reaching populations that are medically underserved, and I think Howard Brown is a critical partner in that work. It's longtime experience working with the LGBTQ community and in the greater Lakeview and Northside community. I think is an opportunity. And to help the whole system improve its delivery of care to our community and our allies. And so I see a real continuum between the work I've been doing at AIDS Foundation of Chicago and Howard Brown. I want to leverage what I've learned in the AIDS fight to help the 16,000 patients that we have at Howard Brown and meet the needs of the community that are not met. I also think, Howard Brown and AIDS Foundation Chicago and many historic AIDS organizations will be under new pressures to realign their business models with the Affordable Care Act. And it's an opportunity for us to really rethink the business model. How do we maximize the Affordable Care Act? How do we reach people who are vulnerable because of their sexual orientation, because of their gender identity, because of their income, because of race, ethnicity, because of their diagnoses, or have experienced trauma. I think this has been kind of the work I've been focusing on at AIDS Foundation Chicago, and in partnership with Howard Brown. And so the opportunity to do this in a clinical setting is very exciting, and I think the mission that I'm really excited about is helping the organization grow and provide excellent clinical services and help our community benefit fully from the kind of promise of the Affordable Care Act, but also trying to work with other partners around the city and the state and beyond to make sure that promise can be extended. I think this is the quest that we're on in HIV. How are we going to make sure that the Affordable Care Act helps people who are living with HIV? And I think it's a very similar path. Many of our patients are affected by HIV, and many are not. And they all deserve excellent services.
Can I ask a question since you bring up ACA? What is that going to mean for an agency like Howard Brown, and not just Howard Brown,
right.
But how does that even impact the future of what an agency like Howard Brown does?
Well, I believe it's a very exciting opportunity because it means that many of our previously uninsured patients will receive insurance for the first time. So that means that they're ability to afford kind of a full array of comprehensive integrated care should be improved. But I think the new challenge is making sure that care is high quality and compassionate and non-judgmental, and meeting their unique needs. Because so having insurance will not. I mean, the conundrum here is that having insurance is not necessarily going to mean that people's health is going to improve. They have to seek care, and they need to have high quality care, and they're still going to need compassionate care. And we have ample experience of people who are mistreated in public systems or healthcare systems because of their sexual orientation or their gender or their race. Won't come back to care, and then their health suffers. So I think this is where I think the work of Howard Brown and really all of our ally organizations is so important. I mean, we have to be part of the system, because otherwise, our folks may have insurance, but they may not find the caring, compassionate, non-judgmental care that they need to get healthy and stay healthy.
Right, and that brings me to a couple of questions I have. I'm glad you asked that. And I have a couple of questions specific to the trans community in particular.
Sure.
There was a meeting that actually, I think, that AFC actually presented at, I think, last September or so. There was a specific consortium designed to answer questions for the trans community on ACA in particular. And there was an entire room of the trans community at UIC. And it didn't seem like the question was asked, what does ACA do specifically for trans people, especially in terms of, for instance, covering surgery, covering hormone treatment? And the answer, after a little bit of fuzziness, seemed to be not a lot. So that in that room, there was a palpable sense of disappointment and frustration about what ACA might actually do for trans people on the ground in very real ways. Sure. So that's one question I have about, and I have two actually, but that's the first one. Can you address that?
Absolutely. I mean, I'll try. I mean, I think that that type of exercise about trying to figure out how can we maximize these tools like the Affordable Care Act for our folks, for our transgender men and women, is going to be so important. And I'm not. I want to be clear. I don't believe that the Affordable Care Act is going to meet all of our needs, and we're still going to. I mean, but it's our duty to try to maximize those opportunities and advocate for solutions. I think you're absolutely right. We are going to face challenges with the ACA for good transgender health. I think we have some better opportunities on the Medicaid side to make sure that individuals have access to hormone therapy, have access to some of their behavioral health needs like counseling, psychosocial counseling, psychiatry, as well as good, internal medicine and family practice, women's health. I mean, so I think we have some opportunities, but we are going to struggle. I believe particularly in the commercial marketplace side of the ACA.
Can you expand on what you mean by that?
Sure. So the Affordable Care Act is really going to help people whose income is 138% of poverty or below, if they're legal U.S. residents, to have access to Medicaid. So the Medicaid program is a joint venture between the federal government and the state. And so it's highly regulated by both federal law as well as state law. And it's going to be the insurance provider for low-income people. And so so in Medicaid systems, we're going to have some opportunities there to meet the needs of vulnerable people who are low income. And for people who are above 138% of poverty, they're going to have access to an array of commercial products, of insurance products, on the marketplace. And it's complex. There are 5 metal plans. They go from the catastrophic coverage, which is bronze, all the way to it's the highest tier of coverage, which is platinum. And so, but all those plans are very different. I mean, in Illinois, there's more than 150 different plans that are offered between the 5 metal groups. and they're configured differently. That means the premium amount is different, the deductible is different.
And what you're saying is also they are not required to cover certain types of things in terms of transgender coverage.
So all of them have different benefit packages, and they do have to meet some standards, some federal standards, but they're pretty broad. We've already encountered this in HIV. So, for example, we found that many of the commercial plans were not covering single tablet regimens. So formulated medications where 3 drugs are formulated into one, either not covering them at all, or in some cases covering them at 50% co-insurance, which means that the insurance recipient is paying 50% of the cost. So that's for most single tablet regimens in HIV, that's $6,000 per year, on top of a deductible, on top of Medicaid, kind of a medical visit copay, on top of a premium. So we've been advocating in Illinois nationally to, one, make sure that these single tablet regimens are part of formularies, and 2, making sure that they're affordable. And I think we're going to have these fights in transgender health. So I want to be clear that the Affordable Care Act is not going to solve all our problems, but it's going to be our job to, one, make sure that people have the education about their options. 2, that they have caring, compassionate, informed medical experts to help them with their needs. And 3, learn from our patients and advocate.
So it sounds like, and this is, there's also been a question about Ryan White and HIV/AIDS as well. Ryan White that we want to talk about, but also it sounds like whether it's HIV/AIDS or whether it's trans issues, that obviously the ACA is going to require perhaps a greater degree of personnel, right? Of people perhaps working just to help people negotiate these. This sounds very complicated for a lay person. So is Howard Brown going, like other organizations, will it have to perhaps expand certain kinds of administrative certain kinds of administrative positions, for instance? Are those in the plan? Is that something? And I know that this is very new for everyone in the healthcare industry. Everyone's kind of trying to figure this out. But what do you anticipate in terms of the biggest challenges for trans people, but also in general as well?
Well, it's a great question. I think this is, your question about the complexity of the Affordable Care Act is much bigger than Howard Brown, in some respects. I think anybody who needs healthcare services or who is insured is going to have the same set of questions. What is the best coverage to meet my healthcare needs today and tomorrow? What is economically the best value in terms of my insurance choices? And once I make a selection, what is a primary care provider that's going to attend to my particular healthcare needs? I think that's really where Howard Brown has a great opportunity, because we attend to the healthcare needs of people that may not get the best care in other settings, or may not feel comfortable in those other settings, talking about their relationships, talking about the realities of their lives, talking about their struggles with substance use, talking about their depression, talking about their sexual histories, talking about their trauma, either domestic or sexual or otherwise. And so, what our mission at Howard Brown must be is to make sure that we are providing the best care for everyone that comes through the door, and particularly for people who are LGBTQ.
And if I may, one of the things I think is really great about what the ACA does for us, it really goes to why we're so excited about David. I think you've just shown in the last 10 minutes of answering these questions your incredible understanding of the policies surrounding the ACA and the repercussions of what those policies will mean on our patients. And you'll be able to build on the resources that Howard Brown already has. I think one of the things that's kind of cool about Howard Brown as an agency and how it's going to relate to the ACA is we have a really great supportive network of case managers that have already been acting as navigators for our patients to help them answer questions about the ACA.
Funded by AFC.
Exactly right. I was going to say, and you know that network so well. You help write that connective tissue that we have to our patients, and make no mistake about it. That exists not only to keep people in a level of understanding with their insurance, but more importantly to keep them adhered to care, because we do have a relatively large portion of our patient population who really do experience challenges getting into regular appointments, making sure their prescriptions are filled. So that network of social support that we've created through the help and partnership with the AIDS Foundation of Chicago will be our network for keeping the really opaque ACA as clear as possible for our patients, and that we've already proven that out in histories. And in one other point, I think it's really, a fact of life, unfortunately, as you've been saying, that even with the Affordable Care Act, we're going to see a portion of the population who won't have adequate health care, whether they be trans, whether they be experiencing chronic conditions, whether HIV or other issues. The charity care that a clinic like Howard Brown provides, Tracy, to your question, where does Howard Brown and similar places sit within this ecosystem now? I think we become even more important, because every dollar that goes into our bottom line, whether we're billing Blue Cross Blue Shield or Cigna or Medicaid, goes to help support our charity mission, and that is to improve the lives of LGBTQ patients and allies within our community. So if you're walking into the clinic and you don't have adequate commercial insurance or adequate Medicaid to take care of what you need as an individual, whether it be trans or otherwise, we're there to help. We're there to help you get those medical needs served. So I think we're more important than ever because of that.
Yeah, if I could follow up on just two points that Duke raised, which are so important. And one of the biggest gaps of the Affordable Care Act is it's not extending these benefits to undocumented individuals. Yeah. And so, the charity care is going to be, a lifeline for people who are undocumented, and making sure that that they can enjoy, good healthcare coverage. So community-based healthcare clinics are going to be, the front lines for undocumented. So that's one. And the other, to your point about, and your question, I think, which is an excellent one, about, the administrative complexity of all this. It's not just making a good selection in terms of the plan, but, really the challenge in healthcare, and this is Howard Brown, but every healthcare setting right now, and Duke alluded to it, is helping people gain access to care and stay in continuous clinical care that's high quality. So care adherence is really important, and and I think Howard Brown has good opportunities to promote good care and treatment adherence through things like the BYC, for example. That's a model. Here we are, creating a safe space for vulnerable young people to drop in, to wash their clothes, to take a shower. We're offering a whole bank of these services, and that's going to create kind of an opportunity for folks to then engage with our counselor, to find out what traumas that they've received, whether they need substance abuse treatment, whether they need to see a physician, whether they have unmet medical needs, whether they need to be enrolled, in insurance, and serve them even if they're not eligible. So, it's kind of, the model's going to be, and we're going to see this in healthcare increasingly, is, medical services at the core, but social services helping avail people ready access to care and retention to care. And Howard Brown is in a good position to do that.
Well, that brings me again then to the second question around the trans population, which is that Howard Brown has been around since about 1974. And as you know, New York City recently instituted a cultural sensitivity, cultural competency requirement in all hospitals for trans care in particular. And Howard Brown, what has struck a lot of us is that Howard Brown has been around for as long as it has been, but the issues around cultural competency around trans people in particular, or vulnerable populations, people with HIV/AIDS and so on, has not been something that Howard Brown seems to have actively, publicly pursued to ensure, for instance, that someone who has to go to Cook County does not meet with insensitive care, which is, as you know, there are harrowing stories from all over about the lack of compassionate care that people receive. So and that brings us to then, you talk about the relationship between Howard Brown and other organizations, and I have a question about that, specifically as to whether the ACA perhaps mandates that as well. But more specifically to trans populations and to people who are vulnerable on other accounts, what will Howard Brown do to actually ensure that it is not the only, there's a way in which being the only organization that provides that care gives Howard Brown a certain amount of power and leaves people actually more vulnerable. If you're not actually training other healthcare organizations to be culturally sensitive, for instance. So what can Howard Brown, or what will Howard Brown do to improve on that?
Yeah, it's a great question. I'm not there yet. Let me just say that. It's my understanding that we have a nurse whose job is to train healthcare workers in Chicago and the Midwest around LGBT cultural competent care, and I think that's important. I think we have to pursue your question or this issue in multiple ways. I mean, I think it's, I think training is very important, and we should continue to do that. But I'm also personally cautious about an over-reliance on training, because a lot of, we see this, my whole background's in HIV, so all my examples are HIV. So I'll just put that out there right now. But we see this a lot with HIV, that we're seeing healthcare systems coming to us and saying, we want to be culturally competent on HIV. We want you, AIDS Foundation Chicago, to come and talk to our case managers for an hour.
Right.
Well, guess what? In an hour, we can only explain to you the difference between HIV and AIDS. But you know what? You can't transmit compassion. I can't teach you to be compassionate. I can't teach you to really know the depth of, the medications, when to start, side effects. I can't, start to begin to unpackage, some of the complex issues around stigma, what you need to know to live well with HIV. There's going to be limits, and I think it's gratifying that there are health systems, using the HIV example, that want to provide their workforce a baseline of information, and that's great, and they should do that. I don't want to minimize that, but at a certain point, we also know that people with HIV are going to get better care from an expert in HIV who really has been committed, whose lives, whose careers have been shaped by responding compassionately and keeping up with evolving HIV medicine. And I think the same is probably true with transgender health. I mean, at a certain point, we just have to make sure that we are working with the partners who have demonstrated a commitment to the population and are really on the cutting edge of good, competent, state-of-the-art trans healthcare. It isn't about Howard Brown. It's about the population. I mean, we've got to find those partners. We've got to work with them. We've got to support each other. And so I think we have to, and we've got to lobby. We've got to fight on the policy front to make sure that the payer sources have, the requirements or are feeling the pressure to respond to the needs of our community. I mean, the same is true, for other populations. Our older adults, they have a whole array of issues that can be very, Chicago and Illinois has a whole system of services for over 50 and over,
And just to follow up, LCCP, the Lesbian Community Care Project, used to be a little bit more service oriented, and now can you tell us what that? Because then they kind of switched more to being about training, because they would have a larger effect by going out and training providers to be more sensitive. So, in this scheme of things, where do you see LCCP falling?
So, I mean, there's some questions I'm not sure.
Okay.
I mean, I do know that our medical practice has been focusing on women's health, which is important to our transgender population, our lesbian population, our bisexual population. I've been impressed by what I've learned about our bench of psychotherapists that have, skill sets with diverse LGBTQ populations. We have a psychiatrist. It's a very important, specialty. We have in our practice folks that are working on geriatric and a pediatrician. So I think we're thinking about, from a practice point of view, and I'm not there yet. Thinking from a practice point of view, how do we meet the needs of the population? But I think, there's some parts of the work at Howard Brown I'm not steeped in yet, and I'm going to learn. And I think part of the mission, my mission, and Howard Brown's, is to turn to the community and inform those answers together. I mean, we need to know what the populations we serve need, and that's an iterative process, and so that's what I'm also excited to start talking to our providers, start talking to our patients, our clients, and our community members, and finding out what aren't we providing that we should, and how do we do it.
Okay. And on the question of LCCP, because I know you haven't had a chance to think about all these questions in the last few weeks, but I can say from the board point of view, we are very aware of the fact that 25% of our patient population is female, 5% of our population is lesbian. And I think the question we need to answer, and I think we're going to be looking to David to help us answer that, is how do we continue to provide culturally competent resources for our lesbian population while also expanding women's health in general for everyone. And I hate to keep going back to the Affordable Care Act, but one of the things that is really cool about the Affordable Care Act as it relates to an agency like Howard Brown is it makes economically viable our ability to pursue certain aspects of female and women's services that we weren't able to afford. Mm-hmm. So we're in very serious conversations now about what the full breadth and width of our women's services will look like. And David will be the one kind of charting that course, but it finally allows us, with the insurance base that we're going to be able to rely on, it allows us to afford it. Mm-hmm. We'll be able to write checks for that type of care that we simply weren't financially able to do in the last few years.
Okay. And that brings me to a question. You've mentioned other organizations, and of course AFC and Howard Brown have been working together in different capacities over the years as well. And does the ACA, does funding for healthcare, we understand is that now with the ACA there's more of an emphasis on community organizations working collaboratively. Is that true? Is there a way in which that's more encouraged on the ACA? That's our...
Yeah, I mean, I think it is, but not in the way that you would assume. I mean, there's nothing in the Affordable Care Act that mandates collaboration. I think what we're seeing is that the whole healthcare system in the U.S. is very dynamic and changing rapidly, and so we're already seeing, for example, hospital practices are aligning with physician practices and with each other, and so I think I think the biggest challenge that I'm anticipating is that in the future we're going to see groups like Howard Brown that before, because most of our clients were uninsured, the competition there was a lot of competition. Now there's going to be a lot of competition for and that's good for consumers. I think consumers are going to have more choice, and I think if we're going to be a destination for care, we're going to have to provide better customer services, better high quality services, and that's a good thing. So I think that's one, and the way we can partner with hospitals, with specialty practices, and provide a total continuum of care through the lifespan. Is good for our mission, good for our patients, good for our community. So that's one way. I think the other is, we are anticipating, that there's going to be a decline over time in health and the availability of public and private grants for healthcare services. And so, increasing the dependence or the utilization of insurance revenue for the models of care that are provided by Howard Brown and our partners, is putting pressure on every organization in health, whether it's LGBT health or HIV or women's health. The state cut, about by 50%, a program to help low-income women with mammograms last year. And that sector, for example, has been scrambling to figure out how do we get mammograms for low-income women. So this trend is beginning. I mean, that's an example. But in the 5 or 10 year window, we may have fewer grant opportunities for the kinds of services that we need to provide the community. And so that means we have to be more innovative in bringing in, and maximizing insurance. So, the sector is really changing. And, I think there's good things about that. For example, I think, we should all feel pressure to provide a better customer experience for our patients and better quality. The dark side of this is, big hospital systems may have more power in the marketplace and may put community-based organizations that historically have been serving vulnerable populations in a vulnerable position. And what that means is if, organizations serving communities of color, LGBT, people with HIV, people with, complex, in and out of prison, if those organizations go away, where are they going to find healthcare providers and social service providers that are kind to them and that are serving them? This is my biggest concern. We've got to make sure that nonprofits and organizations serving vulnerable populations survive this transformation, because the lives of our communities depend on making sure that they have not only insurance but they have good, high quality, culturally competent care.